sir, uh, previously it was like one case they were giving, and you need to take like whole history and then examination and all that.
Okay.
Now they are just giving one fundus case, like patient will be there,
Okay.
and you need to just examine the patient and tell whatever like finding you got. Just
Okay.
explain the finding. So
Okay.
pattern is like that.
Okay.
So
Fine.
just I am presenting one case like that I encountered in OPD,
Sure. Sure. Sure.
superior superior
Hey,
RD.
everyone can unmute and maybe then can raise some queries or anything. Yeah. Amol, go ahead.
So sir, 64-year-old male patient came with the chief complaint of sudden diminution of vision in the right eye since 3 months. The patient was apparently all right 3 months back when he was complaining of when he was 3 months back. Uh, the patient have a diminution of vision in the right eye since 3 months back. Hello.
You got muted. Yeah. So
Yeah.
sudden diminution of vision next.
In the right eye since 3 months, sir, which was sudden in onset, uh, progressive in nature, and progressive and painless in nature. For that, patient went to local doctor, and there he advised surgery for that. The patient here actually came for second opinion. There was no any history of trauma. There was no any previous surgery. Sir, I'm just telling what are positive findings, like protocol, like complete that past history and all that. What are the significant findings? Just I will tell, sir.
Okay. Okay. Fine.
The patient was using spectacle for 10 years, and the patient was moderate myope. Like patient was having a refractive correction of -6. A spherical correction was there. He was using, and there was family history of myopia also, and there was no history of trauma or like surgery significant. But and there was no any family history of any RD. So like that was the positive finding. And the patient in the family history also, there was no any history of RD, and for that there was any laser or something like surgery not done previously. So I will come to the examination. In examination, fundus examination, I will come sir directly. In fundus examination, the fundus was examined by indirect ophthalmoscope with 20D lens. The right eye media was clear. Disc was vertically oval with well-defined margins. With normal, sorry sir. Uh, Disc was vertically oval in size, vertically oval in shape, normal size.
So just hold
With
on
cup
one
disc.
second. Yeah. So Dr. Nikita, is my voice audible? Yeah, you can just. So is there any significance of disc in a case of RD? What do you think? Any importance of disc finding? You can just unmute and answer. Anyone else? Yeah, Dr. Nikita, please.
Yes, sir. If risk is involved, then visual prognosis will be bad if we treat the RD.
Okay. So see, one thing you must understand that disc will never be involved in any case of RD. Okay. So because there is no the nerve fiber layers, only the ganglions are going through that. So disc will never detach. Okay. Yes. So importance of disc is that for glaucoma. Okay. First of all, if there is glaucoma, then your management will change. Okay. You may not be able to do some surgeries. you may want to do some, your prognosis will change. Secondly, there can be a case of serious retinal detachment. Okay, if there is a optic disc pit. Okay, so that is very important when you talk about disc. Okay, so Amol, you started with
Yes, sir.
20D examination. Would you like to do anything else before going for 20D?
Um, like I would for fundus examination, sir.
For examination, yeah, you are going to examine the fundus. Is there anything
Yeah.
else you would like to do before seeing the fundus?
Yeah, I would like to do optic nerve head examination by
No.
90D.
Yeah. So on slit lamp examination, before checking the fundus, is there anything else you would like to see?
Like in anterior segment or any slit lamp, like.
On slit lamp, something, if you know this is a case of RD, what would you like to see before seeing the
Uh,
fundus?
yes, sir. I would like to see, and is there any NVI which indicate long-standing RD? Also, I would like to do, is there any signs of trauma?
Okay, fine. Anything else?
Signs of, and um
So the
like
Dr.
intraocular pressure.
Can you just unmute yourself? Dr. Poonam Wag, are you there? If it is comfortable, Dr. Poonam Wagmare. Okay, someone else. Dr. Ruchika?
Sir, I would like to,
Yeah, please. Dr. Ruchika, would you like to add something?
uh, sir,
Yeah, go ahead.
yes, I would like to see tobacco dust. Like, is there any pigment in the anterior vitreous?
Absolutely, very nice.
Suffers.
Okay, so whenever you see RD, first of all, you have to start with pupil, whether the pupil is there is RAPD or not. Okay, if there is RAPD, that means there is extensive retinal detachment. Okay, that means there is not a localized retinal detachment. Retinal detachment is there for quite some time, and it is a significant retinal detachment. Then it is very important to see the cataract. Okay, because cataract will change your management. Okay, presence of cataract, pseudophakia, aphakia, that will change how you go ahead with the case. Okay, then comes the anterior vitreous phase. Okay, so if there is anterior vitreous phase, you see on slit lamp, you see for presence of pigments. Okay, if there is pigments, what does it suggest, Amol?
It suggests the retinal tear. There is a there's a release of pigment. So basically, retinal tear is there and indicate the regmatinous retinal detachment.
Absolutely. So there is very high chances that there will be a retinal detachment, and especially if it is a case of trauma and you see Schaffer sign or tobacco dust sign. Okay, so tobacco dust sign is also known as Schaffer sign, and you have to see it on slit lamp. So in a case of RD, it is very important that you have, even if you don't check, when you start after your history, you should say, I would like to see this patient on slit lamp to check for tobacco dust sign or Schaffer sign. Okay. And also in case of trauma, why you want to see anterior vitreous phases, you want to see if there is presence of RBCs, that is, there is presence of vitreous hemorrhage. If there is vitreous hemorrhage, that is also more chances that there may be RD. Okay, this can be even in case of PVD induced. If there is a PVD induction and there is vitreous hemorrhage, there is a lot of chances that there may be formation of a break. Okay.
Yes. Yes.
Yeah. So go ahead.
And sir,
Yeah.
for one more thing, that in the optic nerve head, myopic chororetinal atrophy is also one of the risk factor for conversion of the moderate myope into the uh, regmatinous. So myopic chororetinal atrophy also one of the things I would
Okay.
like to see.
Fine. I am not aware, but if that is one thing, then yes, definitely myopia would be a risk factor. And that is one thing where you should always see that I would like to see the refractive error of the patient. Okay.
Yes. Yes.
Yeah. So go ahead with your
Uh,
20D.
yeah. So disc was vertically oval, normal size, pink in color, with well-defined margins, with cup disc ratio of 0.3. The blood vessels were arising from the center of the disc and diagonally branching superiorly and inferiorly, and with AV ratio of 2/3. Uh, the foveal reflex was present. Macula was normal. There was a retinal elevation from 12 o'clock. Sorry, from 2 o'clock to 11 o'clock.
Okay, 1 second. So, Dr. Shubhangi, would you like to tell me why the foveal reflex is important? Dr. Shubhangi, are you there? No? Okay, Dr. Nikita, you would like to tell me why the foveal reflex is important in a case of RT? So if the foveal reflex is present, that means what? What does it suggest? If the foveal reflex is normal?
Macula is healthy and
Yes. So if the macula is healthy, that means your retina detachment does not involve the macula. So it is a macula on retinal detachment. Okay. So now, Dr. Poonam Wagmare, would you like to tell me what is the importance of a macular on retinal detachment? Dr. Poonam, are you there? Okay, Dr. Sneha. Yeah, Dr. Poonam. Would you like to answer? No? What about Galaxy J7? Would you like to answer? What is the importance or significance of a macular on retinal detachment? Anyone else? Dr. Sneha? Would you like to answer? No?
To counter the picture regarding the visual prognosis, because the visual prognosis won't be same.
Very nice. Anything else you would like to add for foveal reflex or macular on retinal detachment?
Sir, if macula is involving or threatening, so I would go for surgery. Like
yes,
it is one.
It is that it is an emergency situation, and you have to be very this quick in the management. Okay, once the macula is off, then you can take your time. That okay, tomorrow is Eid, and after that I am going out, so maybe you can come back later. But if it is a macula on retinal detachment, then maybe today or maybe tomorrow morning you have to post the case. Okay, so that is very much important. Yeah, go ahead, Amol.
So there was a retinal elevation seen from 2 o'clock to 11 o'clock, with the loss of choroidal pattern, and it was looking like corrugated undulating membrane, and the, there was loss of transparency, and the retinal break was seen at the full thickness defect was seen, which was circular in size, at 12 o'clock, with the red base, which is most probably suggestive of retinal break. Yes,
Okay.
and rest of the.
Dr. Poonam, what is the importance of corrugation and undulating movement? Would you like to take this question? Anyone else would like to volunteer? Galaxy J7? Dr. Ruchika? Dr. Ruchika, you would like to take this question? Okay, yeah. Dr. Nikita, you can tell me what is the importance of undulating and corrugated appearance? Okay, so Amol, just tell me what is the importance?
Yeah, So if the undulating movement is there or corrugated surface is there, so it will indicate one, it is a fresh RD, and second, it is mostly it is looking like a regmatinous retinal detachment, and the fluid is underneath it. So that is the main indication that which undulating
Yeah.
movement. So
So what?
RD,
So if in a case of exudative RD, how will the appearance be?
it will be turbid, like turbid SRF will be there, and the fluid shift will be minimal, and here fluid shift will be there, and there will be a concave, there will be convex surface. Uh, yeah, that will be in exudative case.
So
Exudative RD.
as you said, the corrugations suggest that it is a regmatogenous RD. In a case of exudative RD, there won't be any corrugations. It will be a smooth convex surface. Okay. Other than that, if it is, there is a frank movement, okay, shifting fluid. So that may suggest that it will be an exudative RD. But fluid shift may be present even in chronic RDs, which are regmatogenous. Okay, so it doesn't suggest, fluid shift doesn't mean that it is a case of regmatogenous RD. And the other thing is that if the appearance, there is no movement, okay, so that means that there is now formation of some fibrosis. Okay, so there is some proliferation of fibroblasts. So what do we call that, Dr. Nikita? Would you like to tell us?
Traction bands.
Fractional bands, yes, in case of tractional RD, but in a case of regmatogenous RD,
Lattice
It would
degeneration.
yeah, no, there is some proliferation, okay, of membranes when the RD is a chronic RD. So what we call as a PVR,
it is
okay, proliferative vitreoretinopathy. So once a proliferative vitreoretinopathy sets in, so these movements will reduce and the RD will become fixed. Okay, there may be proliferation of bands, not tractional bands, but we call them as fibrotic bands or subretinal bands. And so this also makes the prognosis for the treatment poor in terms of the surgical anatomical success will also become little poor. Okay, so that is why it is very important. Okay, and once there are these, the movement is lost and still there is a break, so then your management also may change. Okay, yeah, so someone would like to describe the holes, the breaks. Dr. Sneha, you would like to take this question? So, Amol, so
yeah.
you said what was the appearance?
It was round in shape with full thickness defect with round in shape with red base.
Yes. So, what does it suggest if it is a roundish hole? What does it mean? What type of break it is?
It is a full thickness retinal break, sir. Type means
Yes. So, it is a full thickness retinal break. But if it is round, then it is more chances that it is suggestive of a degenerative break. Okay. That means it is a hole rather than a tear. Okay. If you see any edge of retina overlying it, or if you see a operculum over it, that means it is a tear. Okay. If there is little vitreous attached to it, that means it is a tear. Okay. So that means if you are saying it is a circular, well-defined without any traction, so that means it is a hole. That means it is a degenerative this. Such kind of breaks are more common in myopic patients. Okay. So
yes.
what are the risk factors for RD in the retina?
Sir, risk factor are mostly moderate to high myo,
Okay.
family history of retinal detachment.
No, what you
Then
see in
the
retina, which will be a risk factor for retinal detachment? What are
mostly a
the
lattice
complications?
degeneration,
Okay.
The lattice degeneration, and if extensive lattice degeneration is there more than 6 o'clock and extensive which so that will be more risk, like, and in retina, if uh, if patient having HST or shift tear, or or JRT, so that will also extend the retinal detachment. So that is the one thing, sir. JRT, HST,
So
and
basically what
lattice.
we are looking for is what are the peripheral retinal degenerations which will predispose
Yes,
to a retinal detachment. So
yes, sir. Lattice degeneration.
yes,
First, lattice degeneration. Second, cystic retinal tuft, tractional retinal tuft.
okay.
There can be a white without pressure. Then degenerative retinocysis. Then myopic chorioretinal atrophy could be there, and zonular tractional tuft.
No, so in case, what are the other peripheral retinal degenerations then, which will not lead to or increase risk of RD?
Not risk factor is a Peostone. It could be PSD. Then white with pressure, or yeah, these two things, sir. White with pressure
What about
and
snail track
having
degeneration?
it is a risk factor, sir.
And what about snowflake degeneration?
Snowflake, I think snowflake is not non.
So
It is not
basically,
risk
you
factor.
need to know all the peripheral retinal degenerations, at least their name and how they look and their significance whenever presenting a case of RT. Okay. So what are the DDs for a round circular lesion which has a reddish base?
Uh, Differential diagnosis, sir.
Yeah, someone else would like to take this question. Dr. Sneha, are you around? Anyone else? Dr. Shubhangi or Dr. Ruchika? Dr. Poonam? And we have with us Dr. Amarnath Avargaonkar. He's a senior faculty from Aurangabad GMC. So he's watching all of us. So we have to be pretty disciplined, okay? Dr. Nikita, you would like to take this question? Yeah, Dr. Tamboli, would you like to tell me what will be the DDs of a break? What else would give an impression of a break? No, you have to unmute yourself. Yeah. So what else is red in color and round in retina? So it could be a hemorrhage. Okay. So Amol, how will you differentiate a hemorrhage from a break? Amol, are you there?
Hello.
Amol.
Hello.
Yes. So how will you
Sir,
differentiate a break from a hemorrhage?
yeah, sir. Basically, hemorrhage, like, it depends upon the location. Is it pre-retinal, subretinal, or intraretinal? So it will give different appearance. But in case of break, you will see there will be defect with a red base, and hemorrhage you will see like a bright red, reddish color. If it is pre-retinal, so it will be very bright. If it is intraretinal, so it will be the blood vessels over it will be blurred. And if it is subretinal. So you can see the blood vessels over it. So that is just basically you will. It depends upon the location where it is present and the defect, the depth, full thickness defect will be
So
there.
it's
That will
very
be absent.
important that you have to differentiate a break from a hemorrhage. Okay, because your treatment and your diagnosis will change if whether it is a rhegmatogenous RD or it is a non-rhegmatogenous RD. So in case of doubt, yes, at times it is very clear, but you have to indent. Okay, when once you do an indentation fundus examination, scleral indentation, that is where you can differentiate between a hemorrhage and a break. Okay, so Amol, how do you do indentation? Amol, are you there?
Hello.
Yeah,
Hello, sir.
yeah. So how will you
Sorry,
do
sir. I think
indentation?
yeah. So for indentation, first you should fix the indenter with the index finger, and I will instruct the patient about the procedure, and I will also explain about it will cause a little bit pain. Then, if I want to check the superior retina, I will instruct the patient to look downward, and then with the help of indenter, I will apply the pressure over the inferiorly to see superior retina, and then I will examine. I will indent
If
moderate,
if you
like
have to
mild to
see
moderate
at
pressure.
12 o'clock, where will your indenter be?
It will be inferiorly, sir.
Okay, so see, this is very important that wherever you are looking, if you want to see a lesion at 12 o'clock, then you have to ask the patient to look at 12 o'clock. Your indenter also has to be at 12 o'clock. Okay, it will never be inverse. It will
Hmm.
give the appearance that it is ulta. But always, if I have to examine inferior, then I have to ask the patient to look down and I have to stand at opposite end. That means if the lesion is at 6 o'clock, I stand at 12 o'clock, ask the patient to look down and my indenter will be at 6 o'clock. If the lesion is at 12 o'clock, my indenter will be at 12 o'clock and I will stand at 6 o'clock. That means the foot end. Okay. It will never be. How can you see a break which is at 12 o'clock by indenting at 6 o'clock? That is not possible physically.
Yeah,
Okay.
yes, sir.
So you will always have to indent at the place where the lesion is. Okay.
Yes.
So that is very important. Okay, and so indentation will also help you to know if there is any traction. Okay, so
Yes.
your break is at what position, Amol?
12 o'clock, sir.
12 o'clock. But where? It is at equator, it is at ora, it is at posterior
Uh,
pole.
at ora, sir, just below the ora, sir.
At ora serrata. Okay, so tell me, how would you like to manage this case?
Sir, as the patient, RD is not involving or threatening to macula. So I would like to observe the patient,
Your
like
RD is superior or inferior, first of all?
uh, superior, sir.
Superior, fine.
Uh,
So you would like
and
to
also, I would like to observe, but also I will give some option to the patient, they have a option so a pneumatic retinopexy option is there. So first, I would like to see is there any spontaneous resolution occurring. So if it is not occurring, then I would like to go for pneumatic retinopexy for the patient. As the break is at the superior level, I can go for option like pneumatic retinopexy.
Okay, so you are not going to observe this case, you have to treat this case. Okay, so what are the three main treatment options possible?
Uh, One is pneumatic retinopexy.
Very good,
Second, I can do the scleral buckle.
very nice.
Also, I can I can drain the SRF and
Okay.
two
So
things.
understand, for any RD, wherever the RD is, there are only three procedures which are there. Okay. One is pneumoretinopexy, one is scleral buckle, third is vitrectomy or pars plana vitrectomy. Whatever be the RD, whatever be the case, these are only the three options. Okay. So we can do pneumatic retinopexy in this. So, but what do you need to ask the patient before going for pneumatic retinopexy?
Like, is there any having problem, any spine problem? Because this patient need a position to
Very
maintain.
good.
So,
Next.
is there any spine problem?
Next.
Then also I would like to like uh, no air travel,
Okay,
and
so patient is going by air. So what is the next option you can have?
I can have like, sir, in patient of this patient, if air travel is not possible, so what are alternative options, sir?
What will happen if the patient travels by air?
Yeah, sir. It will cause the it will increase the uh, 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 pressure, sir, in the eye, because of the sudden expansion of the gas.
Very
Because
nice. Very nice. Very
uh,
nice. So,
in this,
so just theoretically, if you encounter such a case in a plane, you are traveling and the patient says, I am having severe pain in the eye. So what do you do there?
um, if severe pain is there, then not understand the question.
Patient is having pain. You are in a flight and the patient is having pain. He has been recently operated. You don't know what surgery has been done. What will you do?
Um, like I have to like outside pressure should be more.
So
I will
basically, it is the high pressure, it is the height of the plane. So basically, you tell the pilot to fly low. Okay. So that is what you want. This is just a theoretical, this doesn't happen. And the pilot is not going to listen to you, even if you tell them to fly low. But this is just for your understanding. Okay. Don't try to do that. Okay. Because there are now a lot of skyscrapers around. Okay. So the option is, so how do you go about pneumoretinopexy?
pneumoretinopexy, sir. Like I will inject I will inject the gas, like options like SF6 is there, then C2F6 or C3F8. These gases I can use.
What is the difference?
So mostly,
Why not air?
yes, sir.
Why not air?
Air actually, sir, it will last for couple of it will 1 or 2 days, and then it will absorb. But
Okay.
these gases will actually provide the RP and retina opposition for pretty long time. So that's why
Yes. So duration,
SF6 will
because the
provide.
gas will be for higher duration, more duration, and they will expand. Okay. So that is why you use. So what is how much does it expand? The SF6 and C3F8?
SF6 are double, and C2F6 is a triple, and C3F8 quadruple.
Okay. And so what, you inject gas and that's it? That is the procedure. Is there anything else you need to do?
Uh, yeah, so subconjunct actually will inject, and then we will ask the patient to
So
maintain
see,
position.
for any retinal detachment procedure, there are always two things which are to be there. One is a tamponade, okay? And second is a retinopexy. That means you do whatever procedure for RD, these two things you have to do, okay? So in this, you have put a tamponade, which is your gas. But what is the retinopexy? Retinopexy means you have to repair the break. So what are the options to do a retinopexy? Would Dr. Avinash
What?
like to take this question? Dr. Avinash? Dr. Avinash, are you there? Okay, yes. Amol, you can answer.
Yeah, one is a laser retinopexy and second is a cryoretinopexy.
Yes.
So,
And historically, what was the earlier thing which was done?
anterior cryopexy.
No.
Earlier, anterior cryopexy. Cryopexy was done.
Do diathermy. Okay. So basically, for today, you have to remember. For theory, it is diathermy, cryoretinopexy, laser retinopexy, and for a practical purpose, there is cryo and laser. Okay. And if the examiner asks you what is one more thing, that is diopexy. Okay, which is not very commonly used, but that is one thing. Okay. So any procedure which you do, you have to do tamponade and you have to do a pexy. That means there is something from inside or outside which will push the retina. That is your tamponade. And there is something which will make the retina adhere to that spot. That is your retinopexy. Okay. So even if you are doing buccal, you will have to use cryo. Even if you are doing a pars plana vitrectomy and you put oil, then you will have to laser around the break. Okay. So this is very important. You do whichever procedure. There is always has to be a tamponade which will push the retina. In a scleral buccal, it will push from outside to in. It will indent the retina. In case of vitrectomy or in cases of pneumoretinopexy, there is a gas or a oil which will from inside push the retina back to its layers, and your retinopexy will be there, which will make it a permanent procedure. Okay.
Yeah. Yes.
I think we are running short of time. So we need to continue with this, or we take it on some other day.
We'll take a now, sir.
Okay, but then I don't know if everyone will get the link